welcome. And I don't think we have anybody here yet. It's still starting, eh? Mm-hmm. Hi guys, welcome on board. Hello. Why are we still starting?
It's a big start.
Oh, 9114. Oh, there we go. Hi everybody on YouTube, Twitter, Instagram, and Facebook. We are super excited to have you on board with us tonight for Fertility Fact or Fiction, March 10th, 2020. We're just going to wait for everybody to sign on and we'll get going from there. Thank you for all the likes. We love you guys. And I think we have a pretty exciting topic tonight because I always like to kind of reveal things that don't work because I hate letting people waste their money. So if it's not going to work, I don't want you to do it. So we're going to chat about that tonight, about a topic that may or may not work. And I'll tell you if it's worth the extra expense. So we'll give everyone a second to join us. I've been fasting all day because I have to fast at this time of year. So cheers to all those of you. This is just water. And I get to eat after this show. So I'm excited about eating. Special thanks to Tarek Ibrahim from IG Strategies, who has always set up all these shows for us. He's awesome. Thank you, Tarek. He's here. And special thanks to my wife, Wendy, who is absolutely amazing and always helps us out with getting everything ready before the show. And my amazing office staff. I love you all. Thank you for working so tirelessly for us. It's been a little hectic with the setup of IVF, so we're super excited to get underway. I've already got a thank you. So thank you for sharing all the good info with us. You are welcome, and I am more than happy to be here to share with you. So we've got some people lining up on Instagram. Hey guys, on Instagram, do we have a thumbs up for sound? Because I always like making sure on Instagram we've got sound. Send us a thumbs up if we got sound on Instagram. Hey Jen, thanks for joining. I see you there now. Haven't seen anything yet. Ooh, good question on Facebook. I'll actually address that one, although we have a billion questions. Okay, we got sound. Thank you to everyone who's saying we got sound. Okay, so once again, welcome to Fertility Fact or Fiction. I am Dr. Rahi Victory. I am a fertility specialist in Windsor, Ontario, in Sarnia, Ontario, and in Toronto, Ontario, where we have offices. So we're going to talk about a couple things tonight. Number one, we are going to address the topic, which is, does double IUI help and improve live birth rates, clinical pregnancy rates, ectopic pregnancy rates, and miscarriage rates? And the number two thing we're going to discuss is what is happening with my work at the Nahal Fertility Program and my work in Toronto and all your precious embryos, and how are we going to deal with all of that. So I'm going to touch on both of those topics, and I'm going to try and get through as many questions as we can. I will end up going through as much as possible. We had a lot of questions in advance. Thank you very much for that. And we'll try and get through those ones as well. So here goes. The topic tonight is whether or not double IUI works. So for those of you that don't know what an IUI is, although I'm sure you're all well informed enough to know about this, an IUI is intrauterine insemination. And that's where we take sperm and we prepare it by putting it through one of several different techniques to sort of wash it, get rid of the debris, get rid of the semen itself, just get the sperm purified, ideally the best quality sperm. And then you kind of put it in what I always describe as like Red Bull for sperm. And then you're going to take that sperm and directly inject it into the uterus of a woman, fairly close to the top of the uterus, where it then just has to go up into the fallopian tubes, and that's a fairly easy pathway to traverse. So with that in mind, some people thought, well, if one IUI is good, maybe we should be doing two. So the first thing you got to understand is how the whole process works. So typically, you're going to aim for getting the sperm in there around the time of ovulation. which you're either determining after you've had a positive ovulation kit, or you're determining because you've triggered the patient with some type of ovulation trigger. More commonly, HCG or Ovidrel is frequently used as well. If that is the method that you're using, the technique some people use is they'll do a 12-hour after trigger insemination, and then they'll also do a 36-hour insemination, which is kind of the most sort of typical time because we anticipate somewhere around 36 to 40 hours you'll actually ovulate after a trigger shot. So if you're doing one, why not do two? Well, the sperm can live inside a woman's body for up to 3 days, 72 hours. And they've done tests in the past to determine that. So we know that women who are undergoing an insemination or even just vaginal intercourse, the sperm can hang around for a while. So if you do it at the 12-hour mark after trigger, and you do it at the 36-hour mark, you know that there's going to be live sperm there no matter when the egg drops. So it kind of makes sense, right? You're sort of hedging your bets. You're doing your best to make sure you've got good sperm there at all times. So the problem with this is it doubles the cost, and it doubles the invasiveness, and it doubles the amount of time you have to spend. So you got to get up from your home, both of you, because it's you and your partner. Or if your partner's supplying this sample, he's got to do it at wherever he is. And then you got to get the sample to the fertility center. You yourself have to go to the fertility center. They have to prepare the sperm. They got to go through the whole process. They got to get you ready for the process as well. And then they've got to do the actual insemination. And typically for places like Toronto, where they do a lot of this, the cost is actually quite staggering. So you're looking at costs that are upwards of $1,000 to $1,200 to do a double IUI. So certainly if it works and it improves your success rates, I am all for it. And yesterday, just flipping through the Instagram comments, I saw someone that jumped up and said it worked for them. And if it did, I'm really pleased to hear that. And I think that's wonderful. But when you actually look at the research for this, it's definitely sketchy at best, and likely is not beneficial. So the first study that's out on this is a large meta-analysis conducted by Morteza Arab Zozani and Carolina O. Nastri. So I've got it here for those of you that need to see it. This is published in the European Journal of Obstetrics and Gynecology and Reproductive Biology, and it's quite new, 2017. It's a systematic review and a meta-analysis, so they pooled a whole bunch of studies together. How many? Well, they took about 400 and some odd studies, kind of distilled it down to the ones that actually had good data in them, which out of that 400 was 15, believe it or not. And then they analyzed those 15 studies to see if when you pool the data from the 15 studies together, you join all the results, does it actually seem to make a difference? Are you actually seeing an improvement in the fertility rates and the pregnancy rates, the clinical pregnancy rates, the live birth rates? And they actually looked at ectopic and miscarriage rates as well, or is this just not very useful? So the most important thing is they had 15 studies, and when they did the analysis, they actually found there was no difference in any of the outcomes that they looked at. So specifically, they tried live birth, no difference. They looked at clinical pregnancy rates, a heartbeat in the baby, no difference. They looked at ectopic pregnancies, which actually I don't think really makes any sense because a single versus a double shouldn't alter that. But in any event, that made no difference. And then they checked whether or not it made a difference in miscarriage rates, and that also made no difference. So the way they do this, and I always like to kind of educate, hopefully you guys can see this line here. And these are all different subgroups and studies. And if this little bar, this diamond-shaped bar here, crosses the line, it means that it is not statistically significant. It has to be completely on one side or the other to demonstrate an effect or a detrimental effect. So when they looked at the men with normal sperm quality, there was no difference whatsoever using single versus double IUI. When they looked at men with mild male infertility, there was no difference. In fact, it looked like it was worse potentially when you did a double versus a single. And when you looked at just everyone lumped in together, unselected semen quality, it showed no estimate. So when they pooled everything together, they showed that there was no benefit, and that was specifically for live birth. You get the same thing when you look at all the other diagrams. So it does not look like that actually makes a big difference. So a little bit later, 2019, there's another study, including one author, which is Richard Scott. And if anybody knows who Richard Scott is probably the smartest man in the world, but definitely in infertility. This is a very, very bright man who works in New Jersey. He is quite well known. He does a lot of talks. He runs a fellowship, and the IVF program he now runs is a conglomerate of a Spanish and an American company. And altogether, they are doing, I think, something like 50 or 60,000 cycles of IVF per year. So he is part of this study. So it's a very large study where they looked over 17 years at almost 11,400 patients. And what they analyzed was whether or not the double IUI made a difference. So in this study, they did say it actually made a difference, but it was 12% versus 14% in couples using their own sperm. So a man and a wife, and they're just using the husband's sperm or boyfriend, girlfriend, whatever the case was. So it went from 12% to 14.1%. So you are basically paying almost double or more in many instances for a 2% increase in the success rate. They then looked at subgroups, and they said that if you were doing it in heterosexual couples and it was using donor sperm, there was a benefit. And that was the one time where it's actually substantial. It went from 8.5 to 17.6%. Now, the problem with that is 8.5% using donor sperm is a really low number. And this was a 17-year study. And so it's complicated to figure out if that actually is a legitimate finding or not. Then they also looked at lesbian and single patients, and they showed that there actually was no benefit to doing an IUI. There was no double IUI, sorry. There was no difference. It was 17.2 versus 15.2, and it was not statistically significant. So, fact or fiction, does a double IUI work? No, it is a fiction. Double IUI is of no benefit to patients right now. If it is of benefit, it is of extremely nominal benefit and certainly not worth the massive increase in time, frustration, expense in particular. So for all those of you that are doing this in Toronto, I would recommend that you stop. For those of you that are doing it anywhere else, again, I'd recommend that you stop. And for those of you that have asked me to do it in the past, hopefully you all know that I strongly discourage doing it. I think we've only done it once or twice in our whole program for people that insisted they wanted to try it, because I'm not into taking money for something that doesn't work. So thank you for sharing that with us tonight and listening in. We're going to get to the questions in a minute. I want to say a brief bit about what's happening with my IVF practice in Windsor and what's happening with my IVF practice in Toronto. So I'm very pleased to announce that I am now working at the Create Fertility program in Toronto, which is Canada's largest IVF center. And very shortly, we will be able to transfer embryos in Windsor. And shortly after that, we'll be able to do egg retrievals as well. Our lab will be set up by Monday. Yay! And so everything is ready to go. I've been speaking to our incredible embryologist recently, and she's all ready to go. For those of you that have embryos still at Nahal, if you have privately funded embryos, so you paid for your full IVF cycle, we will simply move them to a location of your choice. I am happy to do that wherever you want, whether you want to move them to Windsor or to the Toronto location. I am happy to support your autonomy, and I want to do whatever you guys want to do. So please let me know, and I'll be happy to accommodate that, including staying at the Nahal Fertility Program, where we can monitor you and send you there. But I do not work there at all anymore, and I would have to have Dr. Payman Mazidi do your embryo transfers. It would not be me going down there to do them anymore. And Dr. Mazidi's lovely, he's a nice guy, but it would not be me doing your transfers. If you have funded embryos and you want to have me do your transfers, you will have to pull out of the funding program, because I have to do those transfers in Nahal, and I will not be going back to the Nahal Fertility Program for various reasons. So I would have to have you pull out of the funding. We are trying to accommodate those requests for everybody right now. We have had some difficulty getting some participation from the hall to get the embryos out, but they have said that if we give them sufficient time, they should be able to do it. And so we are working towards that goal right now, with about a 2 to 3 week wait, according to them, to process everything. So we've set up the shipping, we've set up insured shipping, instructions are being sent back and forth between the various programs, and we will have everything ready to go for you if you want to withdraw from the program. Keep in mind, if you withdraw, you will have to pay for your subsequent embryo transfers. We're going to cover the costs of your shipping by reducing the initial payment and covering the costs of your monitoring for your embryo transfer. But beyond that, you'd just be paying like any other patient who has privately funded embryos. For those of you who would like to stay in the fertility funding program through Ontario's fertility program, I cannot have anything to do, unfortunately, with those cycles. I'm very sorry about that. Believe me, it was never my intention. I wasn't expecting to be in this situation at all. I had always intended to continue going there and doing my embryo transfers, but unfortunately, certain things have occurred that just don't make that possible anymore. So what we would have to do is have you see Dr. Mazidi, and you would have to discuss your case with the Nahal Fertility Program. They will then go over the instructions with you. We've tried to get some answers as far as monitoring is concerned from them for those cycles. At present, we do not have a contract with the Nahal Fertility Program, so I really can't answer questions about monitoring. You will have to ask them. I don't know what their plans are or how they intend to do it. But again, keep in mind that it would be Nahal and Dr. Mazidi that would be making the decisions for you, deciding when your lining is ready, deciding what progesterones to use, all the medications and so on. We would no longer be involved in that aspect of your care. And we would actually be allowing you to sign over to Dr. Mazidi, and he would then have access to your charts. I would then not have access to your charts until such time as you wanted to come back to us, and you are always welcome to come back. But for the interim, you'd have to kind of choose one physician or another. So that's the story with me and my new practices. So Create's fertility program is huge. They are very large. I am very appreciative to Dr. Cliff Liebrack. We're actually going to have him interviewed on the show very soon. He's an incredibly bright guy. He's set up an enormous practice, and it's a very sophisticated place with a lot of excellent technology and customer service. And because of that, I selected that because I really want to deliver the best care that I possibly can to all of you. So thank you to all those of you who have been patient during this process. We will ask you to continue being patient where possible as we navigate through the difficulties we have right now with Nahal, just trying to coordinate embryo releases. So as long as we give them sufficient time, they've told us that they can do it, and I am doing my best to accommodate that. Okay, so Tarek is with us, and I think we'll flip back and forth between Facebook and YouTube, Instagram, Twitter. He's going to ask some questions from Instagram, I guess. You want to start with those ones?
Yeah. So first question is, how many days or doses of progesterone before a FET cycle?
So days or doses typically is 5. You should have completed 120 hours of progesterone exposure. There are some people that believe that you may need longer or shorter, and that's the whole fertility factor fiction on the ERA test, the endometrial receptivity array. And we did that months ago. So there's no evidence that that works, but some people really strongly believe in it. So typically 120 hours, so 5 days of progesterone.
Next question is, why do your chances lower the more IUIs are performed?
So there was a study done when I was a resident, actually. I think the dinosaurs were still roaming back then. So back in the day, they said that up to 6 insemination cycles was okay, but that if you went past 6, you actually decreased your success rates. The reality is, if you are going that far into doing insemination, there's got to be something wrong. I mean, just doing repetitive inseminations over and over and over again doesn't make sense. There's got to be something else we can do and something more we can do for those patients. So I don't think it's reasonable to just keep plowing through insemination. It's much more reasonable to say, hey, we've got to find something that works. Let's figure out what that something is, and then let's kind of take the appropriate steps. Sometimes that's doing more diagnostic tests, sometimes it's surgery, sometimes it's changing the medications you're on, and then sometimes it's needing to move to IVF. So certainly in Ontario, where things are pretty regulated, there have been physicians that have actually been penalized for doing too many IUI.
So the next question is super related, if not exactly that question. After 2 failed IUIs, is it better to go to IVF considering the already high cost of IUI meds?
It depends on which IUI meds you're using. So if you're in injectables and you're spending thousands, I actually discourage people from doing that. So typically if you're seeing me and you're doing what we call COH IUI, so those are the injectable meds and then insemination. If you don't have coverage, I'll really have a robust discussion with you about saying, look, this is going to be fairly expensive. It's not a huge increase in your success rates. So you need to be kind of cautious about making that choice. If you are going that direction, yes, certainly. If you've done 2 and you're paying out of pocket for the meds, I would probably stop at that point and I would switch to doing IVF. If you are not paying out of pocket, however, it's your insurance that's covering the meds, I think it's totally reasonable to do it more than 2 times. Somewhere around 3 to 4 is generally considered okay. And then again, you need to reinvestigate and consider what your next options are. Let me take a Facebook one here. So someone's asked on Facebook, progesterone suppositories versus injections, what is the better option? So there is actually some fairly good data that says that if you are taking in progesterone injections, especially for IVF, that it is better than doing the progesterone suppositories. However, I actually use both, and many places do. So we'll use vaginal progesterone and we will use injectable progesterone. You cannot get the same blood serum levels of progesterone vaginally as you can through the injectable, and you probably can't get the same uterine progesterone through the injectable as you can through the vaginal. So we use both to make sure we are covering both your serum levels, which would naturally be in your system when releasing an egg, as well as the uterine levels, which are very close because the ovary and the corpus luteum, which produces the progesterone, are right next to the uterus itself. So it's a short sort of jaunt for the progesterone molecules to get to the uterus.
All right. Should you avoid sugar around embryo transfer day and a few days after?
I wouldn't say avoid sugar, but I wouldn't go on one of my own famous chocolate binges. So I probably keep the sugar to a minimum. You always want to keep your processed sugars to a minimum anyways during infertility. It can cause inflammation. Inflammation is bad. So keep the sugar content fairly low. But if you need to put some, sugar in your tea or coffee, that's not going to affect anything. Let me take a quick Facebook one here. I live an hour northeast of Toronto. I used to live an hour northeast of Toronto. If I wanted to come to your clinic for a paid IVF cycle, how would it work? Do I have to attend your Sarnia or Windsor clinic for all appointments, monitoring, etc.? No, we can get you monitored pretty much in a variety of different locations. I have partners that I work with in multiple sites. So that's not a problem. We can have you monitored in and around Toronto. And then when you are ready for your actual egg retrieval, we will be more than happy to take you either at Create in Toronto, if that's more convenient for you, or here in Windsor. So you can have your choice of whichever one you want. I am trying to give my patients options. So you just tell me what's best for you, and that's what we do. How many C-sections can someone have? Hi, Nick. Yeah, so after 3, the risk of placental abnormalities, including placenta previa, where your placenta has come down, has stuck over your cervix, or increta, accreta, percreta, where it's actually invading through the wall of the uterus and sticks to it permanently, drastically increases. So if you are facing more than 3 C-sections, you are going to be at an increased risk. So in those cases, I do caution people to be careful. I always want to leave you with your options, but I also want you to know that it's risky and there could be complications. Placenta previa can be life-threatening. Placenta accreta, increta, percreta can require surgery, including hysterectomy at the time of delivery. The risks are small, but they do increase quite significantly once you've gone past 3. So I think more than 3, you're risking things. Yeah.
Would you transfer frozen embryos if the uterine lining is less than 8 millimeters?
If it's a triple layer and you've done your best to get it up there, there's a lot of discrepancy between what people think is acceptable, but typically 8 is kind of the standard. But some people will accept a 7, and I've even transferred into people with a lining that was 3 millimeters. So there are ways to test it. We're exploring some new interesting things. Mara Lucato from a long time ago, a friend of mine, she has brought us the Matrix test, which is an ultrasound test that can tell you if the lining is ready. Apparently it works quite well. We're just trialing it now. There are other techniques like the ERA test, which I no longer use very often, but we do when we have cases where we just can't get the lining to be robust enough. So I still turn to it in those cases. So you have to take each case individually. You got to make sure you are doing as many tests as possible to make sure you're giving the patient the best possible opportunity.
Is there anything to think in uterine lining vitamins or something?
There's lots of things. So obviously estrogen is the main agent that thickens your lining. Vitamin D has been shown to thicken it. Vitamin E has been shown to thicken it. Aspirin probably can because it improves blood flow. Acupuncture has been shown to increase your uterine thickness or lining thickness. Viagra can do it. And then there's the wacky stuff like the protein-rich, the platelet-rich plasma that we spoke about last week, as well as GM-CSF, which is granulocyte macrophage colony stimulating factor. So that also can do it. So there are some techniques we can use for the people that are really resistant, but not everybody responds. Some people just have a thin lining no matter what we do. Let me take a Facebook one. What protocol would you suggest for someone with low AMH? Also, what advice do you give on someone with blood clotting issues? Okay, so low AMH, there's a lot of different choices. There's natural cycle, there's mini cycles, there is the duo stim we talked about recently, which we're going to have up and running shortly. There are various protocols to stimulate you. So there is the Lupron flare, there are letrozole cycles, there is estrogen priming, testosterone priming, human growth hormone. Every patient is different, so it's not reasonable to say everybody gets the same thing. So I kind of talk to you about your options and we try and custom tailor it to your physiology and your biology, but there are different choices you can use.
Thoughts on protein powders? Are there any to stay away from before starting an IVF cycle?
I've never been asked that before. Protein powders generally are quite a heavy load of protein, and they're not really necessary unless you're actually bodybuilding. And it's got a ton of dairy and then a whole bunch of amino acids and supplements. And it is a bit of a high protein load all at once for your kidneys. I'm not sure I'd recommend anybody be on protein powder prior to infertility or during infertility. If you want to have a little bit, I'd probably take like a half scoop, nothing heavy like the 20-25 gram ones. I'd probably stick with something that's around 10 grams. And I'd probably be taking that in slowly, not like one big gulp, but over the course of, several hours.
What tips do you have for patients for successful FETs?
Oh my God, that's a big topic. We could spend hours on that one alone. If you go back through the fact or fictions, you'll see tons of stuff that's related to FET. So let's talk about the basics. So you want your lining to be really good. So that's important. You want to check compression of your lining after you've started progesterone. You want to make sure that your progesterone levels are being monitored. That can be very important. Vitamins and supplements. So appropriate diet, keep your cholesterol low, keep your sugar low, keep the inflammation low. Make sure that you are exercising and that your weight is not a significant issue because high BMI does decrease your success rates. And then additionally, make sure that you are on every vitamin that is helpful. So vitamin D, C, A, all of the antioxidants, coenzyme Q10, omega-3 fish oils, all of these things can have an impact. And then, of course, folic acid, iron, B12, these are all important as well. And then actually going through the process, calm. So you need to be as relaxed and as psychologically stable as possible. That's why we've built up our huge sort of psychological program here at VRC. We want to make sure that we are addressing all of your emotional, psychological needs as we go through the cycle. So make sure that you address that part of things as well. That's kind of a real basic answer for a really complicated question, but that kind of touches the overarching elements of it. Let me ask one for here. What protocol? Oh, sorry, I forgot to touch on blood clotting issues. Aspirin and heparin, that's easy. If you have blood clotting issues, you should be on aspirin and heparin during your cycles. What is the average cost of an IVF cycle, including ICSI and assisted hatching with FET at your clinic? Do you do payment plans? So we just set up the pricing all together for everything, including all of those things that you mentioned. It'll be $99.95 Canadian. It's a tiny bit more if you're American because we have to charge insurance, but it's about $1,000 more. So it's not really onerous. It's still about a third of what it would cost in the US. The pricing is really competitive with everybody else, and that includes everything, including a year of freezing your embryos and maintaining them, and your first embryo transfer is included if fresh. If it's not fresh, we only charge $500 for the first frozen transfer. So that's the cost. And we do not have payment plans, but we just met with Scotiabank and they are quite interested in creating them for you. So we are working on that diligently to have payment plans available. Okay. What will happen with patients on your funding list at your Sarnia clinic that haven't started any cycles yet? So Create, God bless them, is giving us some funding, so we will move it to there. And for everybody else, I need you to create quite a ruckus so that the government will fund us here in Windsor, because we have a large population between Sarnia and Windsor and Leamington and Chatham. And we are currently working with the MPP from Chatham and Windsor area to get funding. He's actually been quite helpful already, and we are aggressively going after the ministry to support us because we deserve it. This is an underserviced area. Patients have to drive a long way, and we want to be able to provide you with what you need.
Another big question.
Uh-oh.
Best advice for unexplained infertility?
Actually, we've addressed that many times. So real quick, unexplained infertility has 4 different things that you can use. You can either do insemination with oral medication, such as letrozole or Clomid. You can do insemination with injectable medications, which currently in the very, very most recent guidelines, they're actually saying is not a great idea because it's not a big improvement in success. And you are seeing a big increase in twins and triplets. But I still think it's reasonable to consider for most patients. You can do IVF, which we know is the best treatment, or you can do surgery. Now, Canadian guidelines actually say that the surgery is not beneficial. I respectfully disagree. If you have endo, we know that operation can improve your success rates. And if you have adhesions, it gives us clues as to what's going on, and that can sometimes help us improve your success as well. So I do think surgery is a reasonable consideration.
What are your general tips for preparing for FET?
Oh, I think we kind of went over that one already. Yeah, let me take one from here. Okay. How do we go about the process of withdrawal from the funded program and getting the process started on having the embryo shipped to you in Windsor? Do I just phone your office? Yes, phone our office. That would be wonderful. Just leave a message because we are getting a high traffic load right now. And we will take care of it. 3,700 patients received an email last night saying that they had to choose whether they wanted to stay with me or transfer to Dr. Mazzidi at the Nahal Fertility Program. Unfortunately, apparently, a lot of them went to their junk mail. So please check your junk mail if you're watching. There is a consent form you have to sign. We will get it up on the website as well. And that way you can sign it and get it back to us. And as soon as we have that, we can, sort of position you wherever you want to go. Each and every patient will receive a response, and we will arrange for the embryos to be shipped out to you at whatever location you wish. How much do I pay for donor? I'm not sure what kind of donor you mean. Donor sperm is about $800 to $900. Donor eggs depends on where the donor is located, and I will happily connect you with our donor egg partners at Egg Helpers. They're awesome and they do a really good job, and we've had tremendous success rates with their program. So we would just put you in touch with them and they can talk to you about those details. I don't get involved in the financials for egg donation at all whatsoever religiously, and we do not find you the donor. We merely put you in touch with Egg Helpers and they then find you someone. So I'll take one more. What are the risk benefits of empirical treatment with injectable blood thinners after IVF transfer? No known clotting disorders, but I've had 2 previous miscarriages and methyl tetrahydrofolate reductase enzyme heterozygous. Risks bleeding, but minimal if you're only on the prophylactic dose, which is what you should be on. Benefits, it does actually look overall like it can be beneficial. So heparins work 2 ways. One is that they improve blood flow because they prevent clotting, but they're actually anti-inflammatory as well. And by reducing inflammation, you're improving your success rate. So we have a lot of success using heparin, and I am a fan of using heparin. So for those of you that have used it, big shout out and send up some likes. For those of you that have not used it, I am a believer if you've had failures before, or certainly if you have a thrombophilia like the MTHFR genes. So that's very reasonable.
I work out 5 times a week. Boot camp style. 3 strength days, 2 cardio. Should I stop during TWW?
Okay, so TWW, if you don't know what that is, that's the 2-week wait. Yeah. In fact, probably stop even before TWW. That's pretty intense exercise, and I'm fiercely jealous because I'm about to go to Jamaica and I do not look like I have a beach body right now, working too hard getting the IVF up and running. But the reality is that's a really strong exercise regimen. And what you do not want to do is reduce blood flow to the uterus or elevate testosterone levels too high after you've done things. So yeah, I would definitely settle that down a bit. You don't want to get your heart rate much over 120. Boot camp is really tough exercise. I would not do that during the 2-week wait. You have another one?
I got Facebook one, but I think all the Instagram ones
they're coming up now.
Those are all valid for you.
Okay, wait. Let me do this one. If you ovulate late, will that cause your period to be late? Also, how long after ovulation can you test for pregnancy? Okay, so if you ovulate late, typically your period should come 14 days after you ovulate. So yes, you'll have your period later, as long as you have a normal luteal phase. How long after can you test? Blood tests about 7 or 8 days. The urine kits, it depends on the sensitivity. Some of them will pick it up from 8 to 11 days. Most of them around 2 weeks. Okay, let me see. How far down are we with, I don't know where the questions are. Is it possible you will be leaving Windsor? No, I am not leaving Windsor. I am not leaving Windsor. I just invested an absolute fortune into building this clinic. I am not leaving Windsor. I love Windsor. The Windsor community and the Sarnia community, Chatham, Leamington, all of you have been incredibly good to us. I would not leave Windsor. I love it here and I love the people here. Okay, let's see. What is the risk of transporting embryos? Short of a truck flipping over, there really is not much risk. And the embryos are coming at $275 with a $25,000 insurance plan. So there is not really a huge risk. Your embryos should be safe. They're going into something called a dry shipper, which is like this sort of yay high tank with liquid nitrogen in it, and it keeps the embryos frozen, and that way you don't have to worry about them until they get here. They're basically going to leave one center, arrive here. My embryologist will take them, put them into our tanks, and then you're good to go. So should be minimal risk. We don't love the idea of shipping embryos around all the time. I have said that before. At the same time, in this circumstance, we don't have a lot of choice because of the fact that I'm not working there anymore, and it has not been a happy split up. So what about international patients? Yeah, we love international patients. We have pricing for international patients. We have donor programs for them. We have surrogacy programs for them. We're insured for them, so no problem at all. If you're an international patient, by all means, give us a shout. You can go through Instagram or Twitter or Facebook or whatever you want, and we will reach out to you and help you out. Absolutely. How do I make an appointment with you in Toronto? Do I need a referral? If you haven't seen me before, you need a referral. If you have seen me before, you don't need a new referral. Just let us know in our Windsor office that you want to see me very shortly. Create will be taking the calls. So I'm just setting that up with Dr. Liebrack this week. Excuse me. Okay. If you are induced with the Foley balloon once, can you be induced again with it, or are there other options for induction? Foley had to be placed 3 times for my first. Was wondering if there were other options. Yeah, you can use prostaglandins. So you can use prostaglandin gels, Prepadil, Cervidil, and these are basically a special chemical that can help your cervix ripen, soften, and open. And in about 10% of cases, it'll put you into labor. There are women that cannot use it. You can't have it if you've previously had a C-section or surgery on your uterus. But they are safe to use, and that way nothing's kind of falling out 3 times. Sorry for that bad experience. What is the best prenatal brand? So I love Progestia from YAD, Y-A-D Pharmaceuticals, and we love Pregvit. So either of those two, but you still need extra vitamins even if you're taking those two. So you want some extra vitamin D, at least 2,000 units a day. And you also want DHA. Those are the omega-3 fatty acids. You are welcome, for the person that just said thank you so much. Okay, I think I'm done on Facebook. Certainly more questions if you have more questions. We got about 20 minutes left. Okay, what is the percentage of people getting pregnant off the first IUI treatment? So it depends on what kind of IUI you're doing. If you're doing IUI natural, it's about 8%. If you're doing IUI with pills, it's about 10 to 15%. If you're doing it with injectables, it's about 20 to 25%. What we have been finding, and I mentioned recently, is that we now use something called the Zymo sperm preparation. And that is a microfluidic device. So you put the sperm on one end, it goes through the other end, and it has to go through this membrane. And the membrane sort of stops the bad sperm from getting through, including, in one study, a 90% reduction in sperm DNA fragmentation between what you start with and what you end up with. So we're getting very high success rates right now. At our most recent assessment in Sarnia, I believe our success rate was close to 33%, which is amazing. So lots of likes for that one. Incredible success rates. Thank you very much to our Sarnia team. We love you, ladies. Definitely really, really impressive. So we are moving more and more towards using that. It is a bit pricey. It's about $100 more our cost. So we're simply passing that on to the clients. So we've gone from about $350 to $450 to use that, but we're leaving it optional. If you want it, we do. And if you don't, we don't. Will you be doing IUI procedures in Windsor? Yes, as of April, we'll have our funding again, so we can start that up. Hello, what is your take on mini IVF for egg quality issues for 40-year-old? No reserve issues. Thank you. Okay, so if you have ovarian reserve concerns, mini IVF is reasonable, but I have actually never understood the purpose. Either you should really just take no medications, because some people believe that helps with egg quality. I'm actually one of them. Or you should take tons of medications because you just want to make as many eggs as possible, and you need lots of meds to do that. If you don't have ovarian reserve issues, you should definitely make more eggs. Because the more eggs you make, the higher the chance you're going to end up with one egg that is genetically normal. And you want the genetically normal egg because that's the only one that has a chance of sticking and turning into a genetically normal baby. There was a recent study that showed that the natural cycle IVF, where we gave almost no meds or very low dose meds, did not improve the genetic outcomes compared to the stimulated IVF. So it doesn't make sense to get one egg over the age of 40 unless you have reserve issues, because we have loads of women that just don't make more than 1 or 2 eggs. For them, natural cycle IVF is a great choice. But if you can make like 10 or 12, then definitely go with the stimulated choice. All good. It was not fun, but so worth it. You helped get my son into this world. Came in scary, but he is here. Thank you, Kayla. Yeah, that is in regards to the Foley catheter. And thank you for looking in your junk mail. Yes, check your junk mail. Those of you who have been emailed, make sure if you had embryos with us at Nahal, you read it, sign it, and get it back to us. How long is your current wait list for new IUI patients using a donor? We don't have a wait list. Just come in. I got to see you, and then we go ahead. So that's not a problem at all. Okay. Did I miss anything? I think that is everything. Oh no, we got more. How are you going to do cycle monitoring for your patients that are now stuck with Nahal for their IVF transfers? Right. So as I mentioned at the start of the show, we're in a bit of a jam on this because Nahal never offered us a contract to monitor patients. I've actually been doing it for free. Because I was working there and I just wanted to help everybody out, including the Nahal people. But now that I'm no longer there, unfortunately, I cannot offer to do the monitoring for free. So we've asked them to provide us with a contract, and so far we have not had the response we were hoping for, or any response at all. So I am a little bit stuck, guys. That's why I've instructed you to reach out to the Nahal program, ask them what they would like you to do. Again, just fair warning to everyone. If you are going to the Nahal fertility program, we have to switch over sort of custodianship of your charts, which I'm more than happy to do. Dr. Mazidi would take them over and he would then address these concerns with you because he's now the medical director there. But you would have to discuss these issues with him. I can't tell you what to do in regards to those cases because I honestly don't know, and I've been asking for answers and I'm not getting the answers either. So I am in the dark along with you at the moment. Can transvaginal ultrasound be done during an IUI procedure? And if it can, does it increase chances of getting pregnant? Yeah, that's a great question. We should do a fact or fiction on that. So the last studies I looked up years ago said it did not help the process. It does depend on who's doing your IUI though. If they're going in too far and it's kind of hitting the top of the uterus, that can cause cramping, which just creates a wave and then everything kind of comes out of there. But with an ultrasound guided one, you wouldn't touch the top of the uterus because you can see it. If you kind of know what you're doing and you're not going in too far, it probably won't make much of a difference doing it with ultrasound guidance or not. You're putting in a fairly moderate volume of fluid, and so that fluid is just going to disperse and go everywhere, including out, but also into the tubes. So I don't think the IUI guidance is really going to make a huge difference. Is there a more critical factor for egg quality between BMI and age? Oh, so you're asking me if your age is more important than your BMI or the other way around? Age is definitely more important, but BMI has a tremendous impact on your overall success rates with fertility. I am very sensitive about that topic because I never want to hurt anybody. We've actually stopped talking about it in the clinic. We will very shortly have it up on the website. I know we've asked about that. Tarek, it needs to very shortly be up on the website. I have a huge document all about the impact of BMI for men and women and how it affects your fertility. But age is definitely greater in women. In men, it would definitely be BMI because age doesn't make as much of a difference in guys. So it depends on the sex. But age is number one in women for sure. And again, it would depend a little bit depending on how old you are. So if you're 25, your age is not an issue versus, let's say, 30, your BMI would be more of an issue at that age. But if you're getting up into, sort of 25 versus 35 and 35 versus 40 something, yeah, it's definitely your age that's the issue. Or the biggest concern, I should say. Can rough intercourse cause miscarriage? Being told absolutely not by another doctor, but would love to know what you think. Okay, so I've never looked up whether rough intercourse causes miscarriage. Trauma can cause miscarriage. So if it's really rough, that could be traumatic. Keep in mind that the cervix is at the top of the vagina, and if you're kind of pounding into it, you are shaking the whole uterus. So yeah, that could be traumatic. I certainly tell all of my patients very gently that no one should be swinging from the chandelier once they've become pregnant. So I tell them to put away the 50 Shades of Grey kit as well. So yeah, I'd probably be gentle. I would not have rough intercourse. I'm not sure who said absolutely not. I'm not really clear that there's data out there. Can you look it up while you're online there? Go to Safari. Yeah, I know. You type in rough intercourse. This could be a very exciting fertility factor patient. Tarek's going to look it up for us. Great question. Yeah, look up, can rough intercourse cause miscarriage? Is a vegetarian, dairy-free diet safe during fertility treatments? Yeah, it's not only safe, it's probably beneficial. So it's very safe. Good for you. I have recently become pescatarian, although because some patients of ours brought in some amazing food for us tonight, I'm going to cheat tonight and have some butter chicken. So thank you, Gina. You are amazing. And your mom as well. I have endometriosis stage 3. IVF failed embryo transfer. Trying to conceive 6 years. I'm taking Lupron before I do another FET. Do you believe this helps with endometriosis or chocolate cysts? Oh, wow. Okay, so first of all, I'm so sorry you're suffering with endo. I am a believer that patients with endo should have surgery, especially if you have chocolate cysts, because the inflammation is so tremendous, you cannot get that to settle down without doing surgery. However, if you're doing a FET with, it says that it stopped the camera.
Oh, okay. No problem.
Yeah. So if you're doing an FET with endometriosis and you don't want to have surgery, and I totally respect that, it's not for everyone. You need Lupron and Letrozole for at least 3 months, preferably 6. And that has been shown in a randomized controlled trial to improve success rates. So there is evidence for that. It's not just that I believe it, I know it. There is good evidence that it will improve your success rates. The chocolate cyst, though, or the cyst of endometriosis, that kind of gums up everything. So I would definitely recommend you consider surgery first, then do the Lupron with the Letrozole 3 to 6 months, and you will see an improvement. I'm very sorry you've been trying for so long. Endo is one of the diseases that really gives everybody a very difficult time. You have my deepest sympathies. If there is some way we can help you, let us know. Even if it's just answering your questions, I'm happy to do what I can. A lot of people, even doctors, don't know that you're supposed to be taking Lupron first, especially Lupron with Letrozole. So it's a good idea. Is there anything on Facebook?
Yeah, there is.
Oh, yeah, there is. Okay. How long is your current? Oh, yeah. How long should a patient stay on heparin? Through first trimester or entire pregnancy? No, if you start stuff in pregnancy, stay on it. So finish the whole pregnancy. And if you have a thrombophilia, the current recommendation is 3 months after. My wife and I want you to be the doctor to deliver our son. She's getting a C-section. Is it possible you can do it? If you're my patient, it's certainly possible. If you are not my patient, we try not to step on colleagues' toes. If you are extremely dissatisfied with your physician for any reason, go back to your family doc, and I'm certainly happy to see you for a referral. But keep in mind, here in Windsor, we have a call system, and whoever's on call delivers all the patients. I was on call last night, so there was one patient that delivered, and I delivered her. And congratulations, she did beautifully. I think that's everything there. Okay, back to Insta. Vitamin D can be used to thicken lining. Should we use a lower dose or no vitamin D at all if you have a very thick lining? No. Even if your lining is thick, you want vitamin D. Vitamin D is clearly associated with your fertility. There's no doubt anymore. Definitely get on vitamin D, and we will find other ways to thin out your lining, like just giving you less estrogen. If we choose to move our embryos to stay with you and withdraw from our funded cycle, what is the private cost of monitoring an FET? So first one would be $1,500. And that's including the monitoring, because we're trying to make up for the fact that you have to pay for the transport, and the hall wants something to move an embryo from one bucket to another, which they deserve something for. So yeah, it's going to be $1,500. Okay, she is your patient. Oh, from the C-section? Well, then it will be me doing it unless you show up at a time when I'm not on call. Then we have hospital rules and I can't do anything about that, guys. Sorry. But if you're my patient, I will be the one to be there to do the C-section. As long as you show up when we've planned it.
So I have a thing on the...
Oh, yeah. Rough sex. Okay, here we go. This is Tarek telling us what's going on.
So in summary, ultimately, it's about how much the male is stimulated for sperm production is what they're actually saying.
For miscarriage
No,
risk?
for
Success?
For success.
No. She wants to know if it causes miscarriage.
Oh,
Look up rough sex and miscarriage.
Doesn't seem to be the case. Doesn't seem to be the case.
All right, we're gonna look it up. Okay, I am 39 and have a three-year-old, I guess, who I got pregnant with via IUI. We are now trying for baby number 2 and are going into our third IUI cycle with letrozole. Is there anything else that could be added? You can do shots, vitamins, acupuncture, melatonin we talked about on Fertility Fact or Fiction. Everybody should be taking that. I'm trying to implement it now. So there's a lot of things that you can do. Stress relief, and the dose of letrozole can be altered. I am a believer in using progesterone afterwards and then aspirin. Everybody should be on aspirin when they're going through fertility. So hopefully that answers the question. Okay. I've been taking letrozole 2.5 milligrams, only one pill for a couple of months, and the doctor told me it was helping me ovulate but was not working, so she upped my letrozole to 2 pills. I pray this works. If it doesn't, I'm about to give up. I don't know what to do. I have PCOS. Oh gosh, I am so sorry. Do not give up. We got loads of options for you when you have PCOS. I always tell my PCOS patients that there are 3 parts to it. So there's the medical part, which is usually letrozole and metformin. Depends on your body mass index and your glycemic index and indices, but we can do both. There's a natural component, which is inositol and NAC, N-acetylcysteine. And if Jennifer Strong's watching, hopefully she's giving us a shout out. Then there is what you need to do. And what you need to do if your BMI is elevated is eat 6 times a day, no more than 1,500 calories per day. And you gotta exercise to build muscle. And walking is not exercise. If walking was exercise, I would be invisible because I don't stop walking usually. But that is what you need. So there are 3 components and you must address all 3. There are loads of options. Do not give up. There are pills we can use. There are natural things we can use. There are shots we can use. There is IUI. There's IVF. PCO is actually the easiest thing we deal with. So absolutely don't give up. There is loads of hope for you. Can you take or use any topical pain reliever for sciatic nerve pain when pregnant? You can take Tylenol, but for sciatic nerve pain, you really need anti-inflammatories, and you're not supposed to use those when you're pregnant. Sorry. So no, don't use Voltaren or anything like that. There is a stretch taught to me by a now family doc, former chiropractor, Joe Thomas. He's an amazing guy. And I get sciatic pain and I stretch it out the way he showed me. I can't demonstrate it on live, guys, but basically it's like doing tree pose from yoga, but then you kind of bend down. And it stretches that whole area and it will prevent you from getting sciatic pain quite a bit. Okay, we're winding down. 1 or 2 more, guys. The evidence seems to be mixed on the effect of dairy on IVF outcomes. Do I recommend stopping? I don't recommend stopping necessarily, but reducing is probably not a bad idea. I'm not a huge fan of drastic changes to anything. Your whole body's homeostasis gets altered. That's not a good idea. So if you want to reduce, that's fine, but don't eliminate. Thank you for taking the time to do these presentations. I very much look forward to them. Oh, thank you. Okay, I think we're done, actually. We answered all the questions tonight with just 1 minute left. Guys, Amazing show. Thank you so much for joining us, Tarek. Thank you so much for looking up rough sex and miscarriage.
It's a big subject.
It's a big subject,
next
apparently.
week's.
We'll make it next week's topic. No pictures for that one. So in any event, thank you all for joining and have a great evening. We will see you again next week, and we look forward to having you on the show. Take care, guys. Have a great week, and stay away from coronavirus. Bye, guys.